Okay, folks, we need to get started here. And the topic of discussion is going to be thalassemia. Fortunately, we have talked a lot about thalassemia already. So you have a pretty good idea what's going on. Let's go ahead and refine what we know about thalassemia. So last time we talked about hemoglobinopathies. What was the characteristic, the general characteristic of hemoglobinopathies? How would you be able to go ahead and define all of them in one sentence?
One mutation.
It's going to be more about the quality, not quantity, of the hemoglobins. So if you have a mutation, you produce the hemoglobin just fine, but under certain circumstances, such as low oxygen tension, the hemoglobin is going to change its conformation, and then that's going to be resulting in a destruction of red blood cells. When we are talking about thalassemias, the story is slightly different. In the case of thalassemia, you don't produce as much. It's going to be about the quantity of the hemoglobin that is being produced. If you don't produce as much hemoglobin, then that is, of course, going to be translated in the patients becoming anemic. Of course, there are many different classes of thalassemia, and that's what we're going to go ahead and discuss today. In general, thalassemias are going to be divided into two main classes. You are going to have the alpha thalassemia, which is going to be affecting the alpha gene on chromosome number 16, and you got beta thalassemia that are going to be affecting the beta genes on chromosome number 11. Remember what we discussed last time. Their genetic pattern is not necessarily going to be the same, and it's going to be a little bit more complex than what you think. It's not like Mendelian genetics that you got a green pea and you got a yellow pea and you're going to go ahead and white pea and you're going to have a yellow pea and you're going to go ahead and have a hybrid pea in between, and that's going to be it. It's a little bit more complex. So if we're going to go ahead and talk about this quickly, we are talking about chromosomes number 11 and chromosome number 16. Okay? You have a pair of chromosome number 11, one from your mother's side, one from your father's side. You got a pair of chromosome number 16, one from the mother's side, one from the father's side. However, on chromosome 11 and on chromosome 16, you got group of genes very close to each other. Okay? Their origin, evolutionary origin, there once upon a time they were one gene. They just duplicated and just mutated, and that's why they're so close to each other. On the 11, you're going to have the beta-like genes. Beta-like. So when we say beta-like genes are going to be the beta, you're going to have the gamma, you're going to have the delta, and you are going to have the epsilon. Okay? These are the beta-like genes. On the number 16, you are going to have two, alpha and zeta. We already know about the ontology of the hemoglobin and its development. What we haven't talked about it, well, you probably know about it, but I want to emphasize it now. This is the time that you have to emphasize. The products of the genes from each one of these genes, the product of those genes are going to dimerize. What do I mean by that? I mean that if you got your beta gene on this chromosome and you got the other beta gene, by the way, what did we call these positions? Alleles. You got an allele for the beta gene, just a normal allele in here and an allele up here. You're going to produce products. The products are going to be beta globin chains. They're going to be proteins. They're going to dimerize. So you will have two beta that's going to be dimerized. On the other hand, when we are talking about chromosome number 16, the story is going to be slightly more complicated. And the reason is going to be that you got two genes on each one of these chromosomes for alpha. So you got what we call alpha 1 and alpha 2 on each one of these chromosomes. You got 4, not 2. When these guys are going to be producing their product, they're going to produce what we're going to call alpha dimers. So you're going to have an alpha dimers. The products are going to make dimers, alpha dimers. And you already know a hemoglobin molecule is going to be a tetramer. It's going to consist of 2 dimers. One dimer on this side, the other dimer on this side. They're going to combine together. Now you're going to have your hemoglobin with 4 globulin chain. Okay? It's pretty straightforward. But it's a little bit more complex than what I just, described to you before in the concept of genetics, the way that things are going to be passed on from one generation to another generation. Let me explain to you several factors that are going to make it very complex. 1. Alpha 1, these 2 alpha 1s are going to only produce 25% of the alpha hemoglobin. Alpha 2 is going to produce 75% of alpha hemoglobin. If you consider that, you understand that if I have a mutation in alpha 1, it's not going to be as devastating if I have a mutation in alpha 2. Did you understand what I said? These alpha proteins that we have in here, they are coming from these genes. But these genes, one of them is going to be a Ford Mustang, the other one is going to be a Fiat, the electric one. The one that is very small. The one that I'm going to buy one very soon. The one that I get into a car accident, I will die. I will not make it out of it. But the bottom line is that, and there's a reason behind it. I'm not trying to keep you in dark about this. I just don't want to get into genetics, because genetics is by itself is a field of science that it just eats you up. It just pulls you in, it doesn't let you go out. Because they have a different promoters. Promoter is something that turns on or off a gene. The promoter for alpha 1 is different from alpha 2. It's much more efficient for alpha 2 than alpha 1. That's why alpha 1 is just only going to produce about 25% of the total alpha proteins, while alpha 2 is going to produce about 75%. I want you to understand, because there's going to be a great variability. Some of you the other day yesterday actually told me that why my thalassemia has so many target cells and my lab mate's thalassemia slide doesn't have as many target cells. Isn't it the same disease? I am trying to explain that to you why they're going to look different. Because it all depends on which one of these is going to be deleted. What do you think is going to happen if you are going to have alpha 1 on both chromosomes deleted versus if you are having 2 alpha 2s are going to be deleted? Do you see the difference? How it's going to be translated in the protein products and how it's going to affect the patient's symptoms? Do you understand what that's going to go ahead and do? The other thing, as if this was not complex enough, we're going to take it one step deeper. And that one step deeper is going to be the terminology that I'm going to keep using from now on. And I will use this terminology on your exams. If somebody is going to have a mutation in beta gene, when we are talking about thalassemia, we are also talking about the beta gene and alpha gene, okay? But if somebody is having a mutation in beta gene, there are several possibilities. Either I'm going to go, first of all, I'm going to have 2 beta genes. Everybody understand? Number 1, number 2. There's no for describing and depicting these genetic combination. So this is the normal, beta, beta. But if you see somebody is being described like this, beta 0, beta, that beta super 0 is going to indicate that there is no beta protein being produced by that gene. 0. No beta protein is being produced. The only beta protein that is going to be produced by this one. Okay, this is nomenclature. This is the way that they describe it by putting these symbols on it, and you're going to understand what is going on. So you need to be able to translate what these symbols mean. Now, on your exam, on your next exam, I give you this, and I tell you what percentage, how much what percentage of the hemoglobin of this individual is going to be hemoglobin A? What's you going to give me the answer?
100%.
What?
0.
0. 0. Because this is telling me this person is not going to be able to produce any beta hemoglobin. And you already know that adult hemoglobin A consists of 2 alpha and 2 beta. But we just said you don't produce, so you're not going to have any hemoglobin A. Okay? But this is not complex enough. Let's make it more complex. I am in torturing mode today, so let me just take it deeper for you to understand. Juliana.
Even if you have the alpha, if you still have the alpha,
Even you have the alpha, what is hemoglobin A? What is adult hemoglobin? Adult hemoglobin is not just alpha, it's alpha and beta coming together, right? So you don't have the beta, okay? It would be like you are building a wall, but there is no mortar among the bricks. That's not going to be a wall, that's going to fall on your head and it's going to kill you. So that's what's going to be the difference. Yeah. Alan?
Can you just repeat that again?
Okay.
He kind of repeated it.
So if you don't produce any beta with these 0 symbols are going to indicate that this gene has a mutation, it doesn't work. This gene has a mutation, it doesn't work. And I asked the question, what percentage of this person's hemoglobin is going to be adult hemoglobin A? And it's 0%.
Because all you have is the alpha, and that just doesn't make it.
Even he has the alpha, that's going to cause a problem. What I am trying to get at in here is that you need to ask yourself this question. Why? So what? You know, you don't produce as much alpha, you don't produce as much beta. Why this person is going to have anemia? Why this person is going to have microcytic cells? Why this person is going to be hyperchromic? And that's where we're going to get exactly what Anthony was saying. Because when you are having an imbalance, what's going to happen here is that the one that you're going to have too much of is going to start binding to each other. So if you don't have enough beta, you know what's going to happen? I tell you what's going to happen. You're going to have alphas to create this homodimer. They're going to go in and create this tetramer. This is not a stable hemoglobin. What is going to do? This is going to go in and precipitate. Every cell that's going to have this type of hemoglobin is going to be sequestered from the circulation, is going to be broken down within either it's not going to come out of the bone marrow, you're going to have intramedullary hemolysis, or if it's coming out, it's going to get cut in the spleen, it's going to get cut in the liver, and it's going to be removed within a matter of a week. Your red blood cell is supposed to stay for 120 days. It's going to be removed in a week. You can see now why they are having anemia. You can see why they are going to have the problems associated with this disease. Julian.
how long can a patient survive?
How long the patient is going to be surviving, it all depends on the different conditions that we're talking about here. In this condition, this is going to be a really tough situation. This person is going to not produce any alpha, any beta. So all he's going to have is alpha. So there are several things that may happen. One is going to be the fact that you're going to raise up other things. So one thing you will be able to see in this person, they're going to have a very high concentration of fetal hemoglobin. Even though they're adults, but they're going to have a lot of fetal hemoglobin. Another thing, you're going to have a lot of A2 hemoglobin. So you would be able to raise in those, but they're going to be severe anemic. Okay, it all depends on whether or not they are getting the care that they need or they're not getting the care, and they will die very early on. Okay? All right, going back to what we were talking about. So you understood this 0. So because of the fact that the alpha genes are going to have different number of alleles in here, I want to describe it a little bit differently when it comes to alpha genes. I will describe it like this. Let's say I got one alpha gene mutated. And remember what we talked yesterday about. Most of the hemoglobinopathy mutations are going to be what type of mutation? Point mutation. Point mutation. Most of the thalassemia mutations are going to be deletion mutations. Let's say that this guy is deleted. How would I be able to depict that using these symbols? It's very simple. So because you got 2 This is the normal genotype. This is the normal genotype. You got 4 alpha chains. You got one of them mutated. That's all you do. You erase one of them and you put the dashed line in here. That is telling me that this person is going to have alpha thalassemia minor. Only one of them is going to be missing. Okay? Only one of them is going to be missing. It's not actually they call this silent. Silent. Because the person is not going to have any symptoms. They might have a few target cells in their blood smear, but they're not even going to know. I have seen many of you students, my students, when I look at your blood, when you go and make that smear of your blood, I look at your blood and I can see there are a few target cells. I know that you're going to fall in one of these categories. You're going to be one of these situations. You don't have any symptoms. You don't know how you have any illness, but you are going to be a carrier of a mutation. We all are going to be carriers of mutation. Don't think this is something going to be abnormal. Every one of us that is sitting in this room is going to have a few, very few, on average about 3 different mutations that nobody else has. Okay? Every one of us has it. Now, if that mutation is going to fall in a gene that's going to have an important function, we have a disease. But 97% of the DNA is not going to be as important as the rest of the 3%. If those mutations are going to fall in those 3%, we are screwed. If it falls in the rest of it, we might not even know it. Okay? Those are silent mutations. Silent mutation. If I'm missing 2, if I'm missing this one and this one, how would I be able to depict that? Simple. Like this. If I am missing this one as well, well, same thing. It's going to be this. And if I miss all 4 of them, this is what we're going to have. This is not going to be compatible with life. Why is it not going to be compatible with life? What is the hemoglobin that keeps the fetus alive until the fetus is born? What is the hemoglobin? F. What is the composition of F hemoglobin? 2 alpha, 2 gamma. You don't have any alpha. So you would have the fetus be born either stillbirth, dead, or will die very quickly after birth. It's not going to be compatible with life. Okay? That's right. That's what we could refer to as alpha thalassemia major, also known as hydrops is a condition in which the fetus will die or be born dead. Now this is a little bit more, we're going to take you a little bit more in depth into this topic, because these are perfect situations to me. You don't produce it or you produce it. But the reality of life is that sometimes things are going to look different. Sometimes you get a mutation on this beta gene, but it is not a mutation that's going to shut it down completely. It's going to be a mutation that's going to interfere with the production of the beta protein. What do I mean by that? Usually this gene, and I'm just throwing this percentage and numbers at you to make a point. There's nothing behind that. I'm not making, I don't know whether or not it's going to be 80%, and if I tell you it's producing 80%. I'm just trying to make a point in here. If you got this gene, when it's fully active in a normal person, it's going to be 80% efficient. If you have that mutation that we are talking about, all of a sudden the efficiency of it is not going to disappear. It's going to go to 30%. Okay? You will have that kind of mutation. The variability that you see in the slides, because they are not from the same patient, most of them is due to the fact that the mutations are not the same. I have told you about this, that the medicine, hopefully, if things are going the right direction, hopefully the medicine will change within the next 20 years. Because the person that's going to have this type of mutation should have a different treatment than the person who is having this type of mutation, even though they both are going to have thalassemia. Okay? It's going to become personal medicine. Based on what your genetic background is, you're going to get a different treatment. And that's beautiful. That's a good thing. Okay? Anytime that somebody talks about that type of medicine, they are talking about good medicine. They are talking about medicine is going to save lives. rather than just put everybody like a sheep in a herd and just treat everybody the same way as if they are having the same disease. They don't. Okay? But right now, the medicine is going through this revolution. And I think I am very excited for you guys because you guys are part of that revolution. And you're going to see the product of that revolution. Things are going to be changing. Please, you just got to make sure that everything goes the right direction. If we go backward, things are going to go the wrong direction. Okay. So, how would we depict that? To depict that, we don't use 0 anymore. We do it like this. Anytime that I put this plus sign in here, I am talking about the beta gene is mutated, but that mutation is not going to stop the production of the beta protein, beta globin. It's going to reduce the efficiency of the production. That's going to make it difficult. You know why? Because now, how much is going to influence it? 30%, 40%, 60%, and that all depends on the individual mutation. We cannot tell you. But be aware of this fact, that if you are having somebody is having a mutation like this, let's say like this, what do you think is going to be the symptom of this person? Minimal. Minimal. This person probably, they don't even know that they have a mutation. What's going to be the symptom of this person? No, it's going to be significant. It's going to be significant. It's not going to be as bad as this one, but it's going to be worse than this one. This doesn't have any symptoms. This one is going to have severe symptoms. This is going to be all depending on what is this mutation. Is this mutation going to reduce the efficiency by 80% or by 60% or by 40%? And that's going to result what kind of symptoms you're going to get out of it. Same thing is going to be valid about alpha. If I have alpha mutation, even though majority of the mutations are going to be deletions, but not all of them are going to be deletions. So I can have this situation. Alpha, alpha, alpha. This is the normal wild type, the genotype. What if I am having this? It means that these two have mutations, which is going to reduce the amount of the protein, alpha protein, that is going to be alpha globin that's going to be produced. Let me take you back here. It all depends on if these two that are going to have the mutation, are they going to be alpha 1? Alpha 1s only produce 25% of the protein. Or they're going to be alpha 2s. Or one of them is going to be alpha 1, one of them is going to be alpha 2. You see how complex it can become. Okay? It becomes very complex regarding the symptoms. That's why you see such a wide range of symptoms when it comes to thalassemia patients. Some of them are sick. Some of them cannot survive a month without transfusion. You got to get transfusion all the time, blood transfusion, to survive. Some of them, they don't even know they have a disease. And you can see how these combinations is going to play its role in the intensity of the symptoms of this disease. Okay? Any questions? So I told you about plus, and sometimes you also have what we call, either alpha S for silent or beta S. There are mutations in here, they're silent, which means that they're not going to have a significant influence on the patient's symptoms. As long as you got one silent mutation, usually you know about it. What I mean by this is this. If you have this situation, beta silent. You got a mutation, but it's a silent mutation. It doesn't cause much. It affects, yes, you got 80% efficiency making the beta protein. The silent mutation is going to bring it down to 65%. Arbitrary number. 65%. You're not going to know you got a problem. But there's a mutation there. Now, if it's not going to cause a problem, why am I telling you? Because I am telling you this because this person is going to marry with somebody with the same genotype. When I'm saying that this person is going to marry somebody who has the same genotype. So this is going to marry a person that is going to be this. Okay? And if you make that Punnett square that we talked about yesterday, what are going to be the possibilities? One of the possibilities is going to be this. Now, this is going to cause a problem. This might reduce the amount of the beta hemoglobin that are going to be produced. So this person is not going to be symptom-free the way that this or this person was. Okay? You understand the concept? All right.
So, how is the silent data any different from the plus?
Okay, because silent beta is not going to influence the function of that gene that drastically. Beta plus is going to be more drastic. Yes, it's going to be much more drastic. It's not going to completely abolish it, but it's going to affect it significantly. Beta silence, it doesn't affect it significantly by itself, but when you're going to have them paired, both of them are going to be mutated, then you would be able to, that the effect is going to sum up. Okay, it's going to sum up, it's going to be added. Okay. Okay. Otherwise, this is primarily the concept that I want you to go down and make sure that you understand. The rest of it is going to be pretty straightforward. We have talked about these things. We have talked about these production of hemoglobin. Now there is, somebody looks at this chart and they just see lines go up and down, somebody would be able to extract information from it. If I give you only this chart, you should be able to understand why people with beta thalassemia don't have any symptoms at birth. You got to understand why patients with beta thalassemia, they start showing the symptoms after 6 months. It's right there in front of you. Okay? It's not something you memorize. It's something you understand. Because of the fact that, look at it, around the 6 months is the time that the gamma is going to go and drop, beta is going to rise. So if you get a mutation in beta gene, it's going to show up now. If you have mutation in alpha gene, it's going to be present at birth. But the beta gene mutations are going to show up 6 months after birth. Up to 1 year, you're going to see the actual full-blown effect of it, because you can see what's going to happen to the gamma. By 12 months, it's going to come down, way down, and the beta is going to be way up. So everything is going to show up now. Okay? So make sure you understand these concepts, because of the fact that everything regarding the patients is going to be due to these facts. You know, which one goes up, which one go down, what kind of mutation it is, you're going to have a different symptom. This is what I explained to you up there. We have a tetramer. We got 4 globin chains to make up the hemoglobin. You always, it doesn't matter what stage of ontogeny of hemoglobin we are talking about. Are we talking about embryological? Are we talking about fetal? Or we are talking about adult? You always have 2 beta-like globulin chains pair up with 2 alpha-like. So if you got 2 alpha in here, you got to have 2 beta-like. So you will not have 2 alpha and 2 zeta together. Sometimes you have conditions like this. 4 alpha together. But this is abnormal. This is not the way that you want it to be. This is when you are having disease. Normal condition, you gotta have 2 beta-like to pair up with 2 alpha-like. And any one of those hemoglobins that we have talked about, Portland, Gower, or even fetal, is gonna follow the same rules. That is going to be 2 alpha-like and 2 beta-like are going to be pairing up together. So pathophysiology of thalassemia. Well, we're going to go ahead and talk about the different types of thalassemia, and you understand. The name comes from which chain, globin chain, is going to be affected. If you got the problem in the beta chain, beta thalassemia. If you got the problem in alpha chain, you're going to have alpha thalassemia. But the problem about thalassemia is different. People, did I tell you that thalassemia is the most common genetic disorder on this earth? Okay? We have on average 300 to 500 million people that are carrier for this gene, is mutant gene for the thalassemia. It's very common. It's all over Mediterranean region, it's all over the Middle Eastern region, it's all over on the west and north and east of Africa, it's all over the far east in Asia, Southeast Asia, it's all around the world. It's the most common one. Now the thing is that the cause of disease when it comes to this kind of, blood disorders such as thalassemia is not because anything but is about the balance. The balance. There's a fine balance. There's a fine balance how much beta hemoglobin is produced and how much alpha hemoglobin is being produced. This fine balance, if it's being disturbed, you will have thalassemia. Okay? Let me tell you quickly why the cells are going to be removed. If you have too much alpha, not enough beta, or if you have too much beta, not enough alpha, you will have an imbalance of hemoglobin. You will have a tetramer of alpha. This will not survive. This will precipitate. If it precipitates, what's going to do? What is going to be the abnormality that you will see in your red blood cells? Heinz bodies. Excellent. Heinz bodies. What kind of morphological abnormality are you going to see in your blood? Pegmatites. See how beautiful everything falls in place. That's why if you're going to have this, or you can have something else. We have something else called hemoglobin H. Hemoglobin H is this. When you are having this condition, you produce hemoglobin H. It's really cool. Chromosome 16 again. You got 4 alphas. Only one of them is working. Okay? This alpha works, the rest of them are not working. They're mutated, they're deleted, they're gone. So you're not going to produce enough alpha. But you don't have a problem with your beta hemoglobin, your beta gene, so you're going to produce the normal amount of beta. But because the beta is going to be in excess, you are going to have these tetramers. Tetramers of beta. This is called hemoglobin H. This is not going to survive. This is going to precipitate. It's going to make you Heinz bodies. It's going to give degmatites. Most of the cells are not going to survive the spleen passage. They're going to be removed by macrophages. Most of them are going to be removed by the macrophages in bone marrow. They don't even get to circulation. Or if you are going to have another type of hemoglobin, this is hemoglobin H. Keep it straight, because hemoglobin H is seen in what disease? What type of disease is going to have the hemoglobin H? Say it. Say it loud. Where was the mutation? How did we name the thalassemias? So you see it in what disease? Alpha thalassemia. But what is hemoglobin H? Is a tetramer of beta. Because you don't have enough alpha. Therefore, whatever is left over is going to go ahead and combine. Same story is going to go for another type of hemoglobin I want you to know about. That's called BART. Just like Bart Simpson. It's going to be a hemoglobin that consists of a tetramer of gammas. Four gammas make a tetramer, and this is not going to survive. These cells are going to be removed from circulation. What do you think is going to induce such situation? What do you think is going to cause this BART hemoglobin to be produced? What is the story about it when you see the result of this formation? Where do you think it came from? Who do you think is going to have this problem? The problem is going to be for people who cannot produce any alpha. Any alpha. So when are you going to go ahead and see this? In what kind of patient? What would you be able to tell me about the demographic of your patients if they are having BART hemoglobin? They're going to be fetal. They're going to be newborns. They are going to be stillbirths. Because of the fact that when is going to be the gamma at its highest? When is the gamma is going to be at its highest concentration? During the fetal age. If you don't have the alpha to match it up, you're going to have the excess of gamma and you're going to have the BART hemoglobin. This is the type of hemoglobin that's going to precipitate. This is the type of hemoglobin you will see on stillbirths. Stillbirths are dead births. The fetus is going to be born dead. And you will have BART hemoglobin in their blood vessels. Because of the fact that all the gammas are polymerized and they beat the dimers and they created this protein, but it's not soluble protein. It's going to precipitate. It's going to create this, precipitation is going to give you the appearance of the golf ball. Whenever you stain the right staining, you're going to see the red blood cells look like a golf ball. All those spots on it is going to be precipitated hemoglobin that are going to be removed. Juliana.
How would the mom know that she just, the fetus has that?
Oh, there will be a lot of symptoms associated with mother's pregnancy. There's not going to be a fetal heartbeat. Mother is going to have eclampsia, high pressure. There are a lot of various things. I'm not an expert in the pregnancy aspect of it, but they will know that the fetus is dead. They will know that the fetus is not developing normal, so they would be able to easily pick it up. But hopefully, if they know the problem with the mother, because you have this situation in which you're gonna have no alpha, okay? You're gonna have a situation in which you're gonna have somebody like this. Okay, is marrying somebody like this. If this is the chromosome and this is the chromosome that passed on to the offspring, that's going to give you Barth hemoglobin. That's going to give you the hydrops fetalis, and that's going to cause the stillbirth. Okay? So usually, Juliana, if you have a patient like this, the patient, especially I'm sure about this country, every time that you go and have a checkup, they do a CBC on you, they will pick it up. Because if you are going to do a CBC, what would you expect to see in the blood of this person? The person that is going to be mutated to have 2 mutated alpha. What's that? Heinz bodies, and not specifically for that one in the CBC result. What would you be able to see? Did somebody say macrocytic cell? Macrocytic and hypochromic. Remember, thalassemia is very similar to iron deficiency anemia. Macrocytic, hypochromic. Anytime that somebody is going to have a lab results that's going to be macrocytic, hypochromic, they will order hemoglobin electrophoresis. Or whatever the new test, HPLC, they do high performance liquid chromatography, whatever the technique is going to be that hospital does. If you're going to have hypochromic macrocytic, they're going to go ahead and do that. Okay? They want to make sure that, hey, of course there are other things that they can do. They can look at your iron level. That's a smart thing to do. They can look at your TIBC. They can look at your transferrin saturation rate. They can go and look at all these different factors to separate, hey, why this person is macrocytic? Why this person is hypochromic? We already know there are several conditions that is going to cause that. Iron deficiency anemia is one of them. What is another one? Chronic disease. Chronic inflammation is going to give you the same picture. What if you have a problem with protoporphyrin production? Exactly. So you would be able to look at these various and be able to separate that, and electrophoresis is going to determine what kind of thalassemia you got. So you're going to get the concrete answer and diagnosis. Okay? All right. Let's go forward. So I just want to emphasize this one more time because it's the most important aspect of this thalassemia disease. The excess of hemoglobin is going to cause the problem. It's not that the hemoglobin does something evil by itself. Gain of function starts because it's not like that. It's just when you don't have the balance, the one that's going to be in excess is going to cause a problem. Not because something is wrong with it, because there is nothing for it to bind. Okay? So it binds to itself, and that's going to produce a hemoglobin that's not going to be soluble. It's going to precipitate, and that's going to cause a problem. So we already talked about this one quickly. Hemoglobinopathies primarily, not absolutely, primarily are going to be point mutations, while thalassemia are primarily going to be deletion mutation. But again, as we discussed with plus and zero signs, you can have a combination of both. You're talking about the overall situation. Now you understand thalassemia is now going to come in different shapes and forms. Now let's talk about beta thalassemia, when you got the problem with your beta chain. If you're going to have beta thalassemia minor, you got a mutation in one of them. You got 2 genes, one of them is mutated, the other one is going to be good. this person is going to have a minimal amount of symptom. Okay? Many of these people are going to be able to continue normal life without any problem or without any kind of treatment. Okay? These are the people that if you do blood smear on them, you will be able to see they're going to be slightly microcytic. If you do a CBC on them, you're going to be able to see they are going to be slightly anemic. But it's their body, because they were born like this, from the 6 months of age, they have been like this, their body has accustomed to it. So they're going to be able to play their soccer game, they're going to be able to run around the way they want to go and do, and they don't have a major problem, okay? But if you are going to have mutation in both beta genes, then you're going to get into another ball game. And that game is going to be the beta thalassemia major, which is going to be very significant. Beta thalassemia major is going to be a condition that if you don't get blood transfusion, you won't survive. Okay? The reason is this. I want you to pay attention to what is happening here. Because in the case of beta thalassemia major, you don't have any beta chains. What is going to be built up? The tetramer of alpha, which is going to precipitate in the red blood cell precursor, the new red blood cells, the fresh, young red blood cells that are supposed to come out of the marrow, they can't. They die. Your kidney recognizes that you are low in oxygen, produces the erythropoietin. Erythropoietin activates the stem cell in the bone marrow to make more red blood cells. So what would you expect in the bone marrow of a person with thalassemia major? Hypercellular, normocellular, or hypocellular? You're going to have hypercellularity. That's another big difference between thalassemia and iron deficiency. Because in iron deficiency, you will not have hypercellularity because you don't have hemoglobin. Okay? But in here, the body tried to replenish all the red blood cells. The problem is that is ineffective erythropoiesis. They're not going to make it to the circulation in this case. They're going to be removed before they even come out, majority of them. So this person is getting the stimuli from every part of the body. We need more cells. What happens is that the poor bone marrow starts making more cells. You remember I told you that after the age of 5 and 7, majority of the bone marrow cavity is going to be filled with, adipose tissue, and the hematopoietic tissue is just going to be at the end of long bones, insert the skull, in the sternum, some of the ribs, and the pelvic is not going to be anywhere else. Like when you're born, you're going to have 100% of your marrow cavity is allocated to hematopoiesis. But as you grow, it becomes decreased. As you get older, it's going to become declining in the space that is going to be directly allocated to the hematopoietic activity. Look at this skeleton of this kid. This is the skull of a kid with beta thalassemia major. Because what's going to happen, because the marrow cannot meet the demand of the body, the osteoclasts start to break down the bone in order to increase the size of the marrow cavity. The marrow cavity becomes so much larger. You can see these hairline on the x-ray. This is the skull of the kid. In order to accommodate the extra production of the red blood cells. So you're going to be able to see this kind of problems. They will have deformability of their skeleton. Let me show you one of these pictures. I might be able to find one for you. Let me show you so they have a very unique feature. I mean, you can see somebody with beta thalassemia major, you would be able to easily identify them by just the features on their face. Because usually the skull is going to be big. The chin is going to be pushed inside. The upper jaw is going to be forward. There is going to be dark eyes. There is going to be separation of the eyebrows. There is a very unique clinical feature associated with beta major. And I don't have my glasses. I don't see anything. So let me see. This is the feature of a beta thalassemia major kid. It's too dark. Let me find something else. You see that? Okay? Or, let me see. This is color. So this is a classic beta thalassemia major. Okay? Except for the problem with the beta hemoglobin, there is nothing wrong with this kid. But you can see how that single mutation or that two mutations are going to go ahead and cause a problem for this person. This person is going to have a very difficult life, and their lifespan is going to be very much lower than your average person. You know, usually they don't make it more than 30 or 40 years old because of the complication associated with beta thalassemia. Think about it. They got to get transfusion every month. You get transfusion every month, you're going to have 100 different problems. Your immune system is going to start attacking the blood transfusion. After a while, you're going to become exposed to it, become sensitized to it. You already know that people who get transfusion, they're going to start storing the iron. They're going to have iron overloading problems. There are so many different problems. They're going to have problem with that, you know, that kind of, you know, beta thalassemia major patients. So they will need transfusion to survive. Okay? All right. We have other types of thalassemia, and hopefully you guys are going to understand this. I told you about the silent carriers. That there is a mutation, but it's not going to affect it, so you're not going to be able to even detect that. But what is the thalassemia intermedia? You remember the one that I told you with plus sign? You remember I told you all going to be depending on what type of mutation you got? You remember I told you that some of these mutations are going to reduce the activity by 80%, some of them are going to do 60%, some of them are going to do 40%. So they're going to create a situation that you're going to have symptoms. They are not going to be as severe of thalassemia major. They are not going to be as easy as thalassemia minor. They're going to be intermediate, in between. And all because of the type of mutation that they have. Thalassemia minor, again, minimal symptoms, characterized by microcytic, not too bad. I would say MCV of 75, around that number. Characterized by hypochromic, okay? You will also may be able to see few target cells. Not too many of them. Target cells are going to increase tremendously when you are moving in thalassemia major. Let me explain to you why you see target. Does anybody know why you see target cells in thalassemia? What was the basic idea behind target cells? What just the basic idea, if you want to describe it in one sentence, how would you be able to tell me the target cells are going to be coming from? Where are they coming from? When you are having low volume and you are going to have a high surface area, right? Right? If you have a lot of surface area, but you don't have enough volume, you're going to have a lot of membrane, not enough volume. And you're going to have this rippling that's going to give you the appearance of the target cells. Right? I know about cholesterol, phospholipid, ratio, but the general idea is that you got too much surface area, not too much volume. Now you understand what the reason is for the target cells in thalassemia? What does that volume consist of? What is the major protein inside of a red blood cell? If you cannot produce it, are you going to have the right volume? Your volume is going to decline. Your surface area is the same, but your volume is going to decline. That's why target cells have become so prominent in thalassemia. But they're going to be more prominent in major or intermediate versus in the minor thalassemia. Question?
I didn't see any myself. Thalassemia? Or no target cells?
You didn't see what?
Thalassemia in target cells.
On the thalassemia major?
It's like, yeah.
Look at it one more time. You show it to me when it comes to it. Okay? Yes, there are going to be. If that's the case, then I would not call that thalassemia. I would call that iron deficiency. If you don't see the target cells, but I got to look at it myself. Yeah. All right. Thalassemia minor. Again, you might see different things. Look at this one. There are target cells here. Wonderful. You can see those. But there are other things in here. Hypochromia. Hypochromia. These are hypochromic. Hypochromia. Hypochromia. Not too bad, but easily 1+ to 2+. You have other things that you don't see in IDA. You don't see in iron deficiency anemia. Basophilic stippling. You don't always see it, but if you see it, it's not IDA. It's not iron deficiency anemia. You see that in thalassemia. But when you move into the other story, when you are having thalassemia major, things become really nasty. Things are really looking abnormal. You look at that film, you know there is something majorly wrong. You will have anisocytosis, you will have poikilocytosis, you're still going to have those basophilic stippling, you're going to have all these abnormal morphologies such as dacryocytes, such as target cells, such as fragmented cells, schistocytes. You will see different things. Elliptocytes, you will see a lot of elliptocytes in the case of thalassemia major as well, such as this one, okay, such as this one. And hypochromic microcytic. And microcytic is going to be really low. You're talking about, below 65. You're going to be between 50 and 65. So it's going to be really significantly different. Many times, as we discussed, your body is trying to help itself, is following the cues that are coming from different places, from your liver, from your kidney. So it's going to try to make the cells. But it can't, because the cells don't make it out of the bone marrow. In that case, you're going to kick into the second mode of survival, which you're going to send the stem cells from the bone marrow to your liver, to your spleen, to your lungs. This is called extramedullary hematopoiesis. Okay, extramedullary hematopoiesis, when you're making the cells outside of the bone marrow. When you are making the cells outside of the bone marrow, a couple of things are going to happen. You will be able to see a lot of immature cells. Nucleated red blood cells. Okay? So don't be surprised if you see immature white blood cells or platelets. They're not going to look the normal way. But one of the most important things that you should remember is the fact that you will have nucleated red blood cells. That's not abnormal. That is very normal. Because now you are making these red blood cells not in the marrow, outside of the marrow, in order to be able to get them out there, because they don't make it out there. Samuel.
What's making the blood cells? The liver?
What makes the
Blood cells.
stem cells? Stem cells divide and make the red.
Yeah, you said it's not going to be produced in the marrow.
Yeah.
Right, it's going to be produced outside of the marrow.
Yeah. Liver, spleen,
Yeah, okay.
lungs, everywhere in your body. You can make it around your intestinal tract.
As an
Anywhere. You just find a place that has blood supply, and that's going to be a place that is going to allow you to make those cells divide and make the red blood cells that you need in the body. But they're not going to look normal, because the environment of marrow is going to be conducive to the production of cells. Environment in the liver is not. Environment in spleen is not. Environment in your lungs are not. So you would be able to see a lot of nucleated red blood cells. You would be able to see a lot of abnormalities such as basophilic stippling, and you will be able to see all those abnormalities show up at higher degree when you are making it outside of the bone marrow. But this stem cell, this cell, it goes to that place, it's going to subdivide, it's going to divide. But the cells don't look as normal. Was there a question back there? Anybody? Okay. All right. So, is there a cure? There is no cure for thalassemia. As of today, we don't have any kind of cure. Anything that comes close to a cure is going to be bone marrow transplant from an identical sibling, identical twin. In that case, you would be able to get bone marrow, because I just want you to realize that bone marrow is a very risky business. About 10 to 20% of the bone marrows don't succeed, and if they don't succeed, the patient will die. So that's the reason that not everybody wants to jump at the chance of having the bone marrow transplant, because there is no guarantee it's going to cause, help you. So, but if you want to get a cure out of this thalassemia, the only way out of it is going to be bone marrow transplant, okay, at the present time. Now, there are drugs that we have. There are drugs that we have to give the patient to help them with the situation. One of these drugs that is still being used today and is very effective is hydroxyurea. Hydroxyurea. Let me tell you what this does. You got to know what they're giving it to the patient. Hydroxyurea increases the expression of fetal hemoglobin by increasing the production of the gamma chain. You see that? So they give the hydroxyurea to the person with the thalassemia major, beta thalassemia major. You're going to increase the gamma. Alpha is not going to be left alone anymore. It got a partner. It's not going to go ahead and become a tetramer on itself. It's not going to precipitate. You're just going to have fetal hemoglobin instead of it. That's, you know, be able to alleviate at least part of the symptoms associated with the beta thalassemia major. There are other medications as well, but overall you can see the problem. You got to replace that hemoglobin that doesn't exist with something else. Fetal hemoglobin is number one. You can also increase the A2, hemoglobin A2 as well, to compensate. We talked about this one as well. You can have problem with the thalassemia alpha chains. You're going to have the alpha thalassemia. You would be able to go, the normal person has 4 genes. You can have be a silent carrier that's going to have missing 1 alpha. It doesn't cause too much problems. Perhaps, you know, slight anemia and slight, you know, hyperchromic microcytic, not too much. But then when you start missing 2 genes, alpha genes, things are going to change. You're going to start have thalassemia trait. You're going to get nice microcytosis as well as the hyperchromic cells. You will be able to see the results. As you continue going down the hole, you're missing 3 alpha genes. You're going to have only 1 normal gene. That's not going to be able to produce enough alpha protein in order to go ahead and have a balanced concentration of alpha and beta. Is going to precipitate as hemoglobin H. Hemoglobin H is going to be tetramer of 4 betas. Okay? And of course, if you are missing all 4 of them, the way that I told you, 2 parents that are going to have the deletions on 1 chromosomes, they're going to pass that chromosome with the deletion to their offsprings. You are not going to have any alpha incompatible with life, hemoglobin BART, and the hydrops fetalis, which is going to cause, that's not compatible with life, the fetus is going to die. And this is basically what I have just told you about. Okay? This is it. This is vital stain. This is supravital stain. I think this looks like chrysoviolet. These are not basophilic stippling, people. This is not right stain. This is chrysoviolet. And all these are precipitation of hemoglobin. All these dots that you see are precipitated hemoglobin H. Is a tetramer of beta. These cells will not survive in the circulation. These cells are going to have a very hard time to get out of the bone marrow. Some of them are going to come out of the bone marrow. They're going to get caught in the spleen. And they're going to be removed. Okay? That's why it's going to be so significantly affecting the patient's symptoms. This is hydrops fetalis. This is what happens when you are going to be missing 4 alpha genes. You're not going to be living. You're not going to be alive. You're going to come out dead and stillbirth. Now, because of, see, when we are talking about gene population or gene pool, let me see how I can go ahead and explain this to you guys so don't confuse you, at the same time be able to go ahead and shed some light over this genetics of these things. When we are talking about gene pool, okay, let's say that we are a country or we are a region in the world, we together. Every genetic chain allele that you guys have. So for example, you know, Misa has 1 mutation in alpha gene. Mark has no mutation in alpha gene. Samuel is going to have different mutation in alpha gene. All of these variation is going to create our gene pool. Okay? Our gene pool is going to be our gene pool. If somebody else is going to come from outside world and join us, it's going to add to our gene pool. Okay? You can see that. Look at how important it is. Understand the meaning of diversity. How good diversity is. Because if this is all the gene pool that we have, if Misa, Samuel, and 5 other people that are going to have this mutation, that is rare mutation, but because we are coming from the same background, we're going to have a lot of that mutant allele. If we start marrying and have kids, the chances of those genetic mutations passed on and become combined in our offsprings is going to go through the roof. Okay? So you will have, for example, give you one example. It's not exactly the same example, but it's going to make the point. We have already talked about in the beginning of the semester about Tay-Sachs disease. Tay-Sachs disease is a lysosomal disorder that's going to kill the child by the age of 2. Tay-Sachs disease is very common among Ashkenazi Jews, okay, because they intermarry. They don't marry other people, they intermarry. And what's going to happen here is that the chances of you and I have Tay-Sachs syndrome is going to be 1 in 10 million. The chances of Ashkenazi Jewish people to have a child with Tay-Sachs is going to be 1 in 200. Because we are the different gene pool. Because the more diversified your gene pool is, the better you're going to be. The safer it's going to be. Because those deleterious mutations are going to become minimal. Because you got to have 2 of them to see the full effect of those mutations. One of them is not going to do anything. You're just going to be carrier. But when they pair up, that's going to cause problem. Now, if you have a different gene pool, the chances of these to pair up is going to go down tremendously. This is the reason you should not marry your cousin. Yes, it is the reason, because you need to understand what the reason is behind it. Not because just somebody tells us not to do that. You don't marry your sister. They used to do it. Cleopatra married his brother, and the pharaohs just married with their sister, and because they didn't want the power to go outside of their family. Yeah, humans haven't changed much, people. Technology has changed over thousands of years. Humans are as assholes as they used to be 2,000 years ago. Have not changed. People that don't always want things for themselves, they're still around. You see them. We all see these people. Okay? So I want you to understand the reason behind things. Because that's the beauty of life, that you understand why something is the way it is. Then you don't need anybody to tell you what to do. You're going to be able to make the right decision yourself. Anyhow, there is a good story in here I want to tell you. And I want to confuse you, because you will get confused, because it's really confusing. When I read it first time a few years ago, I said, wow, how am I going to be able to explain this concept to my students? And let me tell you this. We are talking about a person who is going to be carrying hemoglobin S, hemoglobinopathy, and at the same time they might be having alpha or beta thalassemia. Let's go ahead and draw it up here so we can keep ourselves straight, not going to get confused too bad. So we have me, this is my chromosome number 11, this is my chromosome number 16, okay? Let's talk about 11 first, just make a point in here. So I got 2 beta genes in here. I have hemoglobin S on one of them, which means what? Which means that on amino acid numbers, the protein that's going to be produced by this gene, on amino acid number 6, instead of glucemic acid, I have what? Valine. That's right. I'm going to put S in here. Okay? But on the other one, I'm this guy with a 0. What? First of all, if you want to categorize this disease, how would you categorize this disease? Is this sickle trait? Is it sickle disease? Is it, what do you say?
Disease.
It's going to be sickle trait, but it's going to act like a sickle cell disease because there is not going to be a good one on this side. So it's going to show its full effect. So this person is going to have sickle cell disease, is going to have sickle cell crisis, is going to have their finger and toes occlusion of the blood vessels and vascular occlusion. They're going to have the infarcts in their strokes, heart, everything is going to happen. Even though they just have one gene. Be aware of that. Okay? Because the other one is a thalassemia. So they don't have a good one. However, the most interesting thing that comes to you in this picture that I want to tell you is going to be relevant to alpha thalassemia and hemoglobin S. Check this out because it's really interesting. So in this case, we got this. We got a sickle cell disease. Okay? We got a sickle cell disease. Yes. What can I do for you? Oh, you have a class? Oh, sure. Okay, sorry. Okay. Okay. So, if I tell you this is not the first time, you're all going to believe me, right? Okay. All right. Listen up. So we are talking about different situation. That was thalassemia that was mixed with beta thalassemia that was mixed with the sickle cell. Now this story is going to be different. You have a patient has the sickle cell disease. You got it? And in here, the person on the alpha one, there are several possibilities. One is going to be you got one single mutation. Okay? Single mutation. You would expect a worse situation in here, right? You don't have, you got the sickle cell disease, so this person is going to have the sickle cell, is going to have low hemoglobin, is going to have everything that is associated with sickle cell. Okay? Now what's going to happen if you are having two mutations? If this person with the sickle cell disease with one mutation in alpha, one of the alpha ones was mutated, is going to have a hemoglobin and hematocrit, I don't know, of 6 and 18. With one. Now when we're going to move to the two mutation story, what would you think is going to happen? What do you think is going to happen? Is it going to get worse or is it going to get better? It's going to get what? I want you to think about what I emphasized in the beginning of the class. Is the ratio. Is the balance that matters. Remember what was causing the problem if you had alpha thalassemia. That if you don't have enough alpha thalassemia, the beta ones are going to go in and make a tetromere and they're going to precipitate and they're going to be removed. Because as you are going to have more mutations in this case, the hemoglobin is going to increase with two mutations. If you're going to have 3 mutations of the alpha with this person who is having the sickle cell disease, hemoglobin and hematocrit is going to go up. Do you see the reason? Because if you don't have the extra alpha ones and you don't have the, you have the sickle cell ones, there is going to be less of these extra alpha ones that's going to precipitate and be removed and cause a problem associated with the hemoglobin H. So what's going to happen here is that the hemoglobin and hematocrit is going to go up and the patient is going to have less symptoms. This is a very unique situation because sickle cell by itself is going to cause a lot of problem. Alpha thalassemia by itself is going to cause a lot of problem. But when you are having together, the problem is going to be declined. This is not going to be true about hemoglobin C. This is not going to be true about hemoglobin E. It's going to be only situation that's going to be hemoglobin S and alpha thalassemia. That actually the combination is going to have reduced symptoms. Questions? Okay.
We would definitely expect to see an increased polychromasia as it improves.
In this case, well, those are going to be relative. You will see expected polychromasia if the person's bone marrow is working fine and the person is not going to be iron deficient and the person is going to be getting enough nutrients and all those things. So those factors are going to decide to what extent you're going to be able to see that. Okay? But yes, under normal circumstances, you will see polychromasia. Absolutely. You will see high reticulocytes. You will see reticulocyte in a sickle cell, you see reticulocyte of 10, 12, 13, 14%. Okay? But again, as you are going to have other problems coming into picture, you are going to be able to see things that are going to change, so the reticulocyte might go down. In here, reticulocyte is going to be, I don't know, 12%, 10%, 8%. Even though you're going to have more mutations. But because of it's all about the balance of these proteins. Rather than this or that, it's the balance that's going to be the key for the survival of the red blood cells. Okay? So we have the similar thing, hemoglobin C and thalassemia. This is going to be hemoglobin C by itself doesn't cause too much harm. But when you're going to go ahead and combine it with thalassemia, then the symptoms of anemia is going to become worsened. It's going to be much more severe, moderate to severe. Same thing is going to be hemoglobin E. Hemoglobin E by itself is going to be symptomless. It's going to be asymptomatic. But the key that most people want to know about hemoglobin E is that this is one of the most common alleles that you find in Asia. So what happens is that thalassemia is also a very common allele in Asia. So what's going to happen if you get the person that's going to have both of these, hemoglobin E doesn't cause any harm by itself. But you combine it with thalassemia, the person develops a severe anemia. It's going to be so severe that this person will need transfusion to survive. Okay? This is hemoglobin electrophoresis. We talked about it yesterday. Let's go ahead and emphasize it. Look what you got in a normal individual. Look, you got hemoglobin A1 too. Do you expect that to see in an adult? You got hemoglobin F. You don't expect to see hemoglobin F in adults, do you? Yes, about 1 to 2%, 1.5% is going to be hemoglobin F. So it's going to be there. But your majority of hemoglobin is going to be hemoglobin A. You know that. Let's see how beta thalassemia trait is going to be. Trait. So we're going to have one mutation, one mutant beta thalassemia. Are you going to be able to see hemoglobin A2? Hey, look at this. It's going to be here. Is he going to see the A2? Yeah. But what is the difference between this and that? There's going to be more about it. Why? Why do you have to want more? Where did that extra A2 come from? When you are going to have a mutant beta 1 thalassemia trait, beta trait, what's going to happen is that your A2 is going to upregulate. Your fetal might upregulate, might not at this stage, but your A is going to decline, and that's exactly what's happening here. Let's compare that to the major. Are you going to have any A? If you have thalassemia major, are you going to have any A's? What is A? 2 alpha and 2 beta. Are you going to have any beta to put it in there? No. What else are you going to have? Look at the amount of F that you have in here. Your F is going to significantly increase. Your A2 is going to be increased. Look at hemoglobin S. You are going to have hemoglobin S, which is going to have a different traveling distance on the gel, on electrophoresis gel. It's going to travel a different place, so you easily can identify it. You will have hemoglobin A2. There is nothing wrong with that. You will have hemoglobin F, fetal hemoglobin. But look at this one. You will have hemoglobin A. Where did that come from? Where did that come from? This hemoglobin A. What is the disease? What are we? Is a trait. So you got one mutant beta. The other mutant is the other beta is not mutant. It's going to make the hemoglobin. You're going to have reduced amount of the hemoglobin A, but you will have it there because you got one good chain, and that one good chain is going to produce 50% of the protein that you need. But if you get into sickle cell disease, there is no more A because you're not going to make any beta. You will have fetal, you will have a lot of sickle, and you will have some A2, but there is not going to be any A. So you would be able to differentiate what the disease is going to be in here. Okay? And again, there are, because of the similarities, and I hope I have been emphasizing enough, anytime that you see macrocytic hypochromic red blood cells, the first thing that comes to your mind is IDA, okay? Iron deficiency anemia. But we cannot jump into conclusion. You got to be able to rule out other things. You got to rule out thalassemia. You got to rule out chronic disease. So what you're going to be able to do, there are different ways of doing it. So there are different tests, people coming up with the idea, for instance, Menzer index. Dr. Menzer, I don't remember when it was, I think it was 1973, that he came up with the idea of Menzer, and we had to learn it when I was in school, but it's not being used anymore. So you get the MCV of the patient, you divide it by RBC. MCV divided by RBC, and it's going to give you a number. If that index is going to be above 13, you got IDA. If it's going to be below 13, you got to have thalassemia. It's not very accurate because people, unfortunately, in reality, whenever you want to do things like that, it always falls 12.5. And you got to be very naive thinking that 12.5 is going to be much different than 13.5. And that's going to be the gray area that most of the time you have to go and make decisions. So it's not going to be very helpful to use. But again, there are a lot of attempts. For me, and I think for you, the best way for you to be able to do that, first of all, the smear morphology. What would you be able to see in IDA or in thalassemia that you're not going to see in other cases? What is in smear? Give me some ideas. Target cells. Basophilic stippling. Okay? Target cells, basophilic stippling. What about polychromasia? That's right, yeah. What about ferritin level? What's going to happen to IDA ferritin level? It's going to go down. Okay? It's going to go down. Are you going to have the same problem with thalassemia? What's going to happen to transferrin saturation? IDA. What's going to happen to TIDC? So to me, transferrin saturation, iron of the blood, the serum iron, as well as the ferritin level are the best way to differentiate between the IDA and thalassemia or any one of the other diseases. Okay? Of course, there are other iron studies. There are a lot of things that you can go and do, but these are not going to be the normal situation. You can easily determine anytime that you have a microcytic hypochromic patient, they always do ferritin on them. They always do transferrin on them. It's just automatic that's being done in order to determine the cause of microcytic hypochromic anemia. And of course, history. History. If somebody comes without any kind of history, they have never had a problem, do you think they're going to have thalassemia? If somebody is going to have thalassemia, with 2 mutations, for example, alpha thalassemia with 2 mutations, they're going to have symptoms. Unless they have never been in this country, they have never been visited by a physician, never seen a doctor, never had any tests done yet. I can understand that situation can happen. But overall, if there is no history of the patient with the problem, it is very unlikely they have thalassemia. Because if you are having thalassemia, you're born with it. You're not going to go ahead and develop it when you're 30 years old. You're going to have the problem throughout your life. Okay? So that history of the patient is number one important thing that you always have to take into consideration. And the rest of it is going to be able to confirm your results. This is just an image of extramedullary hematopoiesis. These are hematopoietic tissue that is being producing red blood cells, white blood cells, platelets outside of the bone marrow. Okay, that's not a normal thing. Okay, one thing, if I see something like that on a patient, if I were a doctor, I would go ahead and do bone marrow biopsy immediately to find out what's going on in the bone marrow. Why these guys are out here and they're not in the bone marrow. And usually they are going to be due to another cell like myelofibrotic. We talked about myelofibrotic anemia yesterday. And because other cells, abnormal cells, cancer cells, fibroblasts, they come inside of the bone marrow and take over the space. There's no place for these guys to divide. They leave, go to other tissue, and they divide. All right. This is going to be the end of this one. How much do we have time? All right. We got one more lecture. You want to take a 5 minutes break?
Yes.
Okay, do this. Then let me stop this. Let's get started again. So, increased destruction of erythrocytes, red blood cells. We are on the last stretch of red blood cells. We're going to finish it up quickly. Middle of next week, we're going to finish up red blood cells. We're going to move into white blood cells. So you're almost done. We're going to talk about the reasons that the red blood cells are destroyed. Okay? How they are destroyed. What happens when they're destroyed. And that's going to be the beginning of the next few lectures. We're going to talk about this one. So the concept is that there are several different classifications that needs to be understood. This classification is going to differentiate between acute hemolysis versus chronic hemolysis. Okay? Acute tells you the name tells you what it is. It happens quickly, it happens rapidly. Chronic one is going to be continuous over a long period of time. I'll give you some examples. If you're allergic to penicillin and somebody gives you penicillin, you are gonna coat your red blood cells. You're gonna have your red blood cells rupture and hemolyze inside your vessels, outside of your vessels. I will tell you within a matter of minutes. Okay, within a matter of hours. If you don't get any intervention, you will die. If somebody gives you a blood that doesn't match your blood, is a wrong match, you're gonna hemolyze those red blood cells that you just got in within a matter of minutes. I mean, I don't know how much you know about blood transfusion. I hope that you learn a lot when you do your blood bank classes. One of the things that the nurses have to do when they are giving the unit to the patient, that they have to stay with the patient. When they go and open up the blood and the blood is going through their veins, they got to take the temperature before they open up the blood, and they have to take the temperature afterwards. If within 30 seconds to 1 minute the patient spikes a fever, they have to immediately stop it. That's telling you there's something wrong. If something is wrong, immediately, I have seen that with my own eyes, within a matter of seconds, the person develops this severe rash all over the body. Immediately, you have to stop the transfusion of the blood. Immediately. Okay? Acute hemolysis can happen very rapidly. Chronic one doesn't necessarily have to be. We have talked about chronic one. If somebody have hereditary spherocytosis, okay, those spherocytes are going to get caught in the spleen. But it's not going to be so severe that these people are going to have severe hemolysis. They're going to have hemolysis all the time at a certain level. They're going to have anemia, but they're not going to lose 50% of the red blood cells in a matter of 10 minutes. It's chronic, it's continuous. Chronic versus acute. Intrinsic versus extrinsic. Sometimes you got problems that are associated with the red blood cell itself. We already talked about this one when we were talking about membranopathies, enzymopathies, okay? All those things are going to be due to an intrinsic problem with the red blood cell. Extrinsic one would be penicillin. Extrinsic one is going to be, I don't know, getting the right blood transfusion or malaria and a parasite infecting your cells. Those are extrinsic ones coming from outside. Inherited versus acquired. That should be clear to you as well. If you are having hereditary erythrocytosis or you are having the hereditary spherocytosis, that was passed on to you through genetic, lineage. That's different from acquired one. Acquired one, something happens that you acquire, you become sensitized to some kind of medication or something, you start developing that hemolysis because of not that you have something genetically wrong with you, because of the fact that you have become exposed to something and your body's immune system is responding to that exposure, and in turn your red blood cells paying off the price. Intravascular versus extravascular. That's going to be very important, and I have seen this on board exams so many times. These two, they ask questions about it on your board ASCP exam. Intravascular hemolysis is the time that your red blood cells hemolyze inside of your blood vessels. Extravascular hemolysis is the time that your red blood cells are being removed in your tissue, such as the spleen, such as your liver. They're going to be different. On average, and I'm talking about these are all average numbers, On average, 90% of your red blood cells, when they become old, when they reach that turning point of 120 days, when they are getting old, they have to be removed. You all know that. Where are they are going to be removed? Primarily extravascularly in the spleen. You got your macrophages. Macrophages are able to identify these old red blood cells because the antigens are changed, because there are differences in their membrane characteristics. They are able to phagocyte those cells, the old cells. They take them inside of their cytoplasm, lysosomes come and release their enzymes, and they break down that red blood cell into its components, and that's the way things are going to progress, and we're going to talk about it right now, what's going to happen to them, okay? Intravascular hemolysis, about 10% of your red blood cells are going to rupture or hemolyze through intravascular hemolysis. I'm talking on normal cases. I'm talking on average normal situation. You got to realize there's a lot of turbulence in your blood vessels. Okay? If you're a red blood cell, as fragile as a red blood cell is, and you fall in the turbulence that is generated by your heart pumping this blood at very high speeds, if you are having places that the red blood cell is going to hit the junction, the wall of the blood vessels, a lot of blood vessels that are going to get old, they're not going to be able to survive. They're going to get lysed, about 10%. 90% extravascular, 10% intravascular. Now, if you are having a shift in this percentage, that's going to indicate disease. That's going to tell you there's something wrong. If you start having more intravascularity than 10%, there's something wrong with that, and you have to determine what the cause is going to be. And that's what's going to be the topic of this discussion today. Now, let me tell you what the normal situation is going to be. If I tell you the normal situation, then you will be able to understand what is abnormal situation. But you got to understand what the normal situation is going to be. In the normal situation, red blood cell that gets old, there is going to be change in the antigen profile on the surface of the red blood cells. There's going to be change in the characteristics of the molecules at the surface of red blood cell. It's going to make it identifiable to macrophages. Okay? As the blood goes through the spleen, what's going to happen here is that the blood is going to slow down. Okay? Like the way that if I have a big sponge and I pour a bottle of water in it, you don't see the water coming out immediately. The water is going to soak into the sponge, then when it saturates the sponge, it's going to come from the other side. Same thing happens with your spleen. When the blood gets into the spleen, it's going to slow down. When your blood slows down, your glucose level is going to go down. Your pH level is going to become acidic, it's going to go down. Your acidity, pH level, your CO2 level is going to go up. All these factors are going to cause stress on the red blood cells. Is a young red blood cell going to be able to respond better, or the red blood cell? It's going to be the young one that's going to be able to get away with it. The old blood cell is going to get captured by the macrophages. We call them splenic macrophages. They're going to take them in the phagosomes. We call these vacuoles called phagosomes. You're going to have red blood cells in it. Then the lysosomes are going to come, and they're going to release their enzymes. Now, they're going to break down all the protein components to what? To amino acids. So the globin chain, alpha and beta, they're going to be broken down to their amino acids. You're going to recycle that. In your body, you don't throw away anything. If you can recycle it, you do recycle it. That's why I say sometimes we have to learn from our own body. Okay? Next time you're going to go ahead and get one of those one-time cups, when you throw it and use it and throw it out to drink a glass of water, you guys got to start thinking about what's going to happen to that plastic cup. Plastic doesn't break down for 300,000 years. 300,000 years is going to stay in the environment. If you think about it that way, you will not, because you are all conscious in here. You all care about your future and the future of this world, because we don't think about this thing. Just use it, just use it. And that's the way that you don't learn from your own body. In your body, you recycle everything that you can. Sometimes you cannot recycle certain things. You have to get rid of it. But most of the time, you're going to recycle everything. Every protein aspect of hemoglobin is going to be recycled to its building blocks, amino acids, and you use the amino acid to do other things, make things, more things, okay? That's going to take care of the protein component. What is left? We got the heme, right? Heme consists of two parts. What are those two parts? Iron and protoporphyrin 9, okay? Iron, the macrophages in the spleen, they got a channel. And you know this channel. Well, let me see whether or not you remember this channel. This channel is going to allow the iron to come out of the cell. What's the name of the channel? Ferroportin. They do have ferroportin, the way that your epithelial cells in your intestinal tract have ferroportin. Same principle. The iron needs to become reduced before it goes through the ferroportin, and it's going to become oxidized. And that is exactly what happens. When iron becomes oxidized, macrophages oxidize this iron to store it in a form of ferritin. But then, when they want to get the iron out of the macrophages, they're going to reduce it. It's going to become outside, it's going to become oxidized, and it's going to bind to transferrin. And the transferrin is going to pick it up and take it where it's supposed to go, such as to the bone marrow. That's where the iron is going to be given to the cells, because transferrin has transferrin receptors, and sits on the receptor, everything is going to be taken out, iron is going to be used up to make more hemoglobin for normal lasts. Alright? But one part is left. And that part is going to be protoporphyrin 9. Protoporphyrin 9 is one of those things that we cannot recycle. We got to get rid of it. How are we going to be able to get rid of it? It's going to be a complicated situation. We got to convert it to something that is going to be less toxic. You don't want protoporphyrin just flowing in your blood. It has properties that's going to oxidize the proteins. It's going to cause a lot of havoc. So inside of the macrophages, we are still inside of the macrophages. In the cytoplasm of macrophages, the protoporphyrin is going to be converted in a compound called biliverdin. Biliverdin. Protoporphyrin is going to be converted to biliverdin. Still, we are in the macrophages. Biliverdin is going to be converted to bilirubin. Okay? Now, bilirubin is ready to go out of the macrophage and travel all the way to the liver. But there is a problem. This bilirubin at this present stage, we call it indirect. Also known as unconjugated. Unconjugated bilirubin. The thing about unconjugated bilirubin is this, is not water soluble. If it's not water soluble, are you going to be able to just release it in your blood? Your blood is 90% water. What's you going to do with that? It's going to cause problem. So you got to have this bilirubin transported with the help of a carrier molecule. It cannot go by itself because it's unconjugated. So you're going to give this to albumin, a carrier protein. Most common protein in your blood is going to be albumin. 55% of the protein in your blood is albumin. Albumin is going to be bound to unconjugated bilirubin. Now albumin has charge. So think about this. If this is the bilirubin, if this is the albumin, this is the way that albumin and bilirubin are going to travel. Albumin is going to dissolve in the plasma, bilirubin in the center of it, so it's going to be able to travel without any problem. Okay? And this albumin bilirubin combination, they're going to get to the liver. They're going to sit on the hepatocytes, and the albumin is going to give the bilirubin to the hepatocytes, the liver cells. Hepatocytes, liver cells, They are going to go in and process this bilirubin slightly, and what they would be able to do is that they are going to add 2 molecules of glucuronic acid to it. 2 molecules of glucuronic acid. So if you have this if I got this bilirubin molecule, you're going to add 2 glucuronic acid to it. Okay? Now what does that accomplish? The only thing that's going to accomplish that is going to convert the bilirubin from unconjugated form or indirect form to conjugated form or direct form. Now what's going to be the difference? What was the characteristic of unconjugated bilirubin? What was the unique thing I told you about? It's not water soluble. This is water soluble. When it becomes conjugated, it becomes water soluble. Now hepatocyte made this. Thank you very much. Because now they're going to go in and get this guy, this conjugated one, and they're going to go in and put it in bile. How many of you guys know about bile? How many of you guys remember from your anatomy and physiology what bile is? I would expect everybody who has taken the body fluid analysis with me to know this without any problem. But I know that not everybody took it with me. What is going to be the bile? Who produces the bile? No. No. I will flunk you if you have taken anatomy and physiology with me if you say that. Liver produces the bile. Gallbladder stores the bile, doesn't produce it. There's a big difference there. So what's going to happen here is that this is the liver, people. Let me go ahead and give you a quick anatomy here. This is the liver. Hepatocytes are going to make the bile. They're going to put it in this duct. There's a duct system. We call it bilar ducts. And there are different names. That's not important what name it is. But it's going to come from the liver. Okay? Gallbladder is going to be in here. It's going to be connected with this tube. But gallbladder is just for storage and concentration of bile. It doesn't produce it. But anyhow, the bile is going to come out. And this is going to be the beginning of your small intestine. We call that duodenum or duodenum. Either one is fine. And bile duct is going to come and empty into the duodenum. It's going to empty duodenum and mix with the food that you have been eating. I have not told you about everything about bile. It's important to know what is the composition of bile. Bile has, of course, you realize it has direct bilirubin, conjugated bilirubin. But bile is also the only way that your body is able to get rid of cholesterol. Okay? Your bile is going to consist of cholesterol. Remember I told you about HDL and LDL, high density and low density lipoprotein? I said that one of them is going to go ahead and get the cholesterol from the liver and take it to the tissue. That was the LDL. They called it bad cholesterol. Actually not the cholesterol, it's a cholesterol carrier, okay? And we talk about HDL, they call it good cholesterol. Not because it's cholesterol, that's going to be good, because it's going to be the molecule that carries the cholesterol from the tissue and brings it to the liver. So you can get it out, and you put it inside the bile, and put it in your intestines. That's the second important component. That's why, people, that's gallstones, when you look at the gallstones, they are all cholesterol stones. They have a lot of cholesterol in it. You look at it under the microscope, it's going to have cholesterol crystals in it. Gallstones are primarily consist of bilirubin and cholesterol. Okay? Another component of the bile that I want to briefly tell you is a lot of salt. We call them bile salts. These bile salts are going to be necessary for the absorption of fat and lipid in your intestinal tract. If you don't produce bile salts, you cannot absorb fat and lipids. Some of the medications that are out there for people that are grossly obese, that's what they do with them. It prevents them from absorption of the bile salts, production of the bile salts, and it's going to prevent the absorption of the fat and lipids, so all the fat and lipids is going to go outside of the body and not going to be absorbed. Okay? That's going to be another important component of the bile. Okay? So what's going to happen here is that when bilirubin that is conjugated is going to come in here, you have, I have told you many times before, you got 10 times more bacteria in your intestinal tract than you have cells in your entire body. 10 times more bacteria. These bacteria are going to start to get this bilirubin, and they're going to start to break it down. Okay? There are several different things that are going to be produced from this bilirubin. One of these things is going to be urobilinogen. See, as this bilirubin is going to be broken down, it's going to travel with the food that you have in your gut, in your intestinal tract. You're going to start absorbing the nutrients. You're digesting the food that you have eaten, and you start absorbing the nutrients, right? With that absorption process, about 1 to 2% of this urobilinogen is going to be absorbed back into your blood. Okay? It's going to come back to your blood. When it comes to back to your blood, the blood from the intestinal tract, the first place that it goes is going to be liver. The blood from the intestinal, when you absorb the food in your intestines, and it makes sense, people, where do you make the glycogen? In your liver. What is glycogen is made of? Glucose. So if I am consuming, if I'm absorbing the food in my intestinal tract, and I'm going to go ahead and get all that glucose, there's going to be rising my glucose in my blood. I don't want it to stay high, because having high glucose is very toxic to the body. You want to have it low amount. So what happens is that the blood that is going to be high in glucose is going to go to the liver. Liver makes glycogen out of it, stores it without any kinds of harm, and anytime that your body needs, breaks down the glycogen and makes the glucose. Wonderful. But there is going to be a 1 to 2% of the bilirubin that's broken down, the urobilinogen is going to get absorbed back. That blood is going to go to the liver. Liver would try to go and remove some of this urobilinogen, but not be able to do all of it. So what's going to happen, the next place that your blood is going to go, the blood is going to go to kidneys. 20% of your blood every minute goes to your kidney. Urobilinogen that goes to the kidney is going to get filtered to the kidney. It's going to filter the kidney, it's not getting absorbed back, it's going to come out of the urine. So the urobilinogen can be measured in the urine, okay? And that would be the way that you would be able to know whether or not there is an elevation of urobilinogen or decrease in urobilinogen. Let me see whether or not you understood what I was just saying. If you have a patient that is going to have elevated urobilinogen in urine, how would you be able to interpret that? What would that tell you? That's right. That's right. Increased hemolysis. You are destroying the red blood cells at a higher rate. So you're going to make a lot of bilirubin. A lot of bilirubin is going to get in the intestinal tract. You're going to break down that bilirubin. So you're going to make a lot of urobilinogen. 1 to 2% of a lot is going to be elevated. So if I say I make 10 urobilinogen molecule, and if I absorb, for example, 10% of it, it's going to be 1 urobilinogen molecule. But if I make 1,000 urobilinogen molecule, and I'm going to go and absorb 1% of it, it's going to be a bigger number. You see that? That urobilinogen with higher concentration is going to come to the blood. It's going to go to the liver, little bit of it is going to come out, then it's going to go to kidney, it's going to come out more. I look at the urobilinogen in the urine, I see elevation. That suggests that I have increased the destruction of the red blood cells, increased hemolysis. Does that make sense to everybody? Did you understand that? Make sure you understand this cycle and this characteristic, because it's very easy. You can make good questions out of this kind of pathways and patterns. All right. So this is what happens. We are talking about normal situation. We talked about what happens to globin chain. We talked about what's going to happen to the iron. We talked about what's going to happen for the porphyrin in the form of bilirubin, and it's going to be removed from the body, and everything is going to work just fine. Now, when you're having intravascular hemolysis, that was extravascular hemolysis, when things are happening in the spleen, macrophages, and those things. In intravascular hemolysis, you have your red blood cells rupture right inside of the vessel. Because of the parasites such as malaria, because of the antibodies that your body produces, because of the medication that you're taking, whatever the reason is going to be, the bottom line is that the red blood cell is going to hemolyze inside of the blood vessel. If it hemolyzes inside of the blood vessel, you know what's going to happen? I'll tell you what's going to happen. Hemoglobin is going to be released into the blood. Okay? If hemoglobin is going to be released in the blood, hemoglobin can be freely filtered in your kidney. And the hemoglobin is going to go and get filtered in your kidney, and it's going to get into your urine, and it's going to go out of your body. Is there a problem with that? What is the problem with that? Didn't we talk about the fact that we don't have a mechanism for our body to be able to get rid of iron? The only way we are able to control the concentration of iron is by controlling the absorption of the iron. Now you are losing, you got a way to lose all this iron that you have obtaining through your diet. You are losing it freely. Because you're not going to be able to maintain it. So the body has 3 specific mechanisms that is going to enable the body to absorb the iron that was ruptured by the damage to the red blood cells intravascularly. 3 mechanisms. One is going to be haptoglobin, one is going to be hemopaxin, and one of them is going to be metalbumin. But in order to know what those are going to be, you got to come next week and I will tell you the rest of it because I'm out of time. So I don't want to take time from your exam. So I'm going to stop at this time, but I told you a lot of things, so I will go through this lecture very quickly. We'll cover 2 more lectures next Tuesday, so be aware of the fact that I'm going to do that. But I'm going to stop at this time. Is there any questions? Ask it. If there's no question, why don't you take off? Come back in 30 minutes. I just want to have that extra 10 minutes for some of you who are going to be needing a little bit extra time to be able to have more time for your exam. So if you want to come back at 12:30, I'll give your exam to you. Okay? All right. That's it then.